Hi, and welcome to another episode of the Healing Lyme Summit. I'm your host, Dr. Mariah Hinchy, and here with me for tonight's discussion is Dr. Richard Horowitz. He is the medical director of the Hudson Valley Healing Arts Center, as well as founding member of the International Lyme and Associated Diseases Society. He has published numerous articles on the treatment of Lyme and tick-borne disease. He has treated over 13,000 patients for Lyme and tick-borne illness over the past 30 years. Welcome, Dr. Horowitz. Tell our listeners a little bit about how you got started treating or specializing in Lyme disease.
Thank you, Mariah. It's great to be here. And I'm really happy to have you as my co-host, by the way. It's been a great experience. So I basically got into Lyme disease simply because my patients needed me to. When I graduated from medical school and moved to the upstate New York area of Hyde Park, New York, I didn't realize I was walking into the largest Lyme endemic area in the United States. And, people were coming in with bullseye rashes. You learned that 28 days of antibiotics, it might have even been 14 days of antibiotics was the treatment. Many would get better, but some wouldn't. And, the ones who came back and were well, it made me think back to a teaching that I got in my last year of medical school when I was in Belgium. And for those of you who don't know a little bit about my background, I have studied with Tibetan Buddhist teachers for the last 40 plus years. And I started training with them back in 1981 when I was in Brussels doing my medical school training when I was doing it in French. And when I was finishing up medical school, I went to one of my teachers, Lama Gendon Rinpoche, and I said to him, Lama, what is the most important thing you want me to know going out into the world as a doctor? And he said to me, Richard, the most important thing is compassion. He said, put yourself in people's shoes and do for them what you would want done for yourself. He says, if you do this, everything will go well. Now, for anyone who has studied any of these type of teachings, you'll know that it is a pretty common teachings probably in most religions, really not that special, but it's interesting that when the Lyme patients came back in and they weren't well, it popped into my consciousness and I went, gee, well, if I was in their position, I would want a doctor looking for answers because at the time I sent them to the infectious disease doctor who did not have an answer. And I sent them to the neurologist and the rheumatologist. Nobody had answers back in the early 1990s. So I started going to Lyme conferences and reading the medical literature and, started speaking to people like Joe Borrascano and Sam Donta and Ken Liegner, who are, the giants whose shoulders I've stood upon. And basically they started teaching me and I started expanding my practice. But it was really just the need of being in the middle of an epidemic, people being sick and saying, hey, I'm a doc. This is my job. No one else is figuring it out. I would want a doctor to figure it out. And 35 years later, 13,000 people later, it's been quite an interesting journey, something I would not have expected.
And you're figuring it out.
We are figuring it out. In fact, this year, I think, was the hallmark with the article we published in Microorganisms, the journal Microorganisms in September 2023 on dapsone combination therapy, comparing longer pulses to shorter. I think for me, that article is probably maybe the best article we have ever published on Lyme because it actually offers for some people the closest to a cure or at least a long-term remission. If we're not getting rid of all the bacteria, we are getting rid of enough that many people using the protocol published in that article are going into long-term remission. So it's a very exciting time. It's taken me a long time to figure it out. I thank my patients, gratefully because they allowed me to play with these protocols and figure it out, explaining the science to them. But yeah, we're in a very good position at this point this year to do a randomized controlled trial on dapsone and show to the world that we do have an answer.
That's wonderful. And to our listeners, make sure that you listen to the discussion that we had earlier on dapsone and the effectiveness of dapsone treatment for persisters. So as far as this talk goes, though, let's talk, I was always taught Lyme and tick-borne disease is a clinical diagnosis. So let's get into that aspect of it. And you've developed a questionnaire that has the ability to detect tick-borne illness in patients about as well as any other test out there. So I'd like you to speak a little bit about the clinical diagnosis of Borrelia, Bartonella, and Babesia. And then let's get into talking about the questionnaire and how to use it.
Okay, great. So first of all, the important point you said that with clinical diagnosis is people out there listening need to know that number one, these are clinical diagnoses. right? So Lyme is a clinical diagnosis. If you have an EM rash, an erythema migrans rash, you do not need a positive blood test, right? So the point being that there are certain clinical symptoms that tell a healthcare provider that you have Lyme. And what we did with this questionnaire that you're referring to, and I, by the way, the name of the questionnaire, that the shortened version, I call it the HMQ, or Horowitz-MSIDS questionnaire. And this questionnaire was developed based on some of the questions which were initially developed by Dr. Joe Boroscano, who had been doing this in Long Island, and of course has paved the way for many of us along the way. But what I did with his questionnaire is I decided to score it. So for example, questions 1 and 22 on the questionnaire are for babesia, day sweats, night sweats, chills, flushing, air hunger, difficulty catching your breath, unexplained cough. If I have a patient fill out that questionnaire, this 38-item questionnaire, which has 4 sections, which I'll discuss with you, and I see questions 1 and 22 positive, and let's say I see moderate or severe for sweats, day sweats and night sweats, it says to me automatically, oh, this patient may have a case of babesiosis, which is a malaria-like organism. Now, always in internal medicine, you always do a differential diagnosis. So I kind of have a way that I've thought about these diseases over the years where, for example, if someone has these sweats, I say to myself, all right, what are the top 8 or 10 causes of drenching sweats? And I've memorized them. And by the way, for those of you who haven't memorized them or don't ever want to memorize them, if you go to my last book, How Can I Get Better, pages 50 to 66, I think it is, it describes for every symptom with Lyme on these 38 items, all the differential diagnoses. So the biggest one, of course, is fatigue, right? Because there's like probably 100 different things that cause fatigue. But for sweats, you have to think of malaria. Did they go to India? Well, now actually we have malaria in the United States and in Texas, right? And in certain other parts of the US, they're now showing up with malaria. But maybe they've got hyperthyroidism. Do they have a cough where they might have hemoptysis, blood in the phlegm? That might be indicative of tuberculosis. Or do they have really large lymph nodes and they're losing weight with drenching sweats? That might be non-Hodgkin's lymphoma. Is a woman over 50? She might have menopause, right? Might have an autoimmune disorder. So the point being, you always have to do a differential diagnosis for every symptom. But the beauty of the questionnaire is by identifying every one of these symptoms, it gives you kind of a sense of what might be going on. And on this questionnaire, of these 38 items, there's specific questions that are very important. Now, Lyme being a multisystemic illness, it means that most people with Lyme, when they fill this out of the 38 items, 30 out of 38, for the most part, in most patients, will be filled out when they come to my office. So it's a multisystemic illness. The way you also can identify it is symptoms come and go with good and bad days. People will tell you, some days they feel better, some days they feel worse. They don't know why. But the hallmark, and this is on the questionnaire in section 2 of the Lyme incidence score, is your pain that you have in your body, joint pain, muscle pain, or nerve pain? And nerve pain can be described as tingling, numbness, stabbing, burning sensations. If you have any of those symptoms that migrate, migratory joint pain, one day your joint pain's in your shoulder, then it's in your knee. Another day you have muscle pain, right, in your thighs, and now it's in your forearms. The pain is moving around your body, and especially the migratory nerve pain. There is no other disease in medicine that causes migratory nerve pain. You can get nerve pain from carpal tunnel syndrome and diabetes and hypothyroidism and heavy metal toxins like mercury, lead, and arsenic, and mold toxicity, B12 deficiency, folic acid. There's many reasons why people can get nerve pain, right? But with Lyme, the migratory aspect tells you it's very likely that someone has active Lyme disease. So in this questionnaire, there's 38 questions. The migratory aspect, very important when you're filling it out. And then I look at the constellation of symptoms. So for example, most of the Lyme patients have fatigue. They have pain, muscle, joint, nerve pain. A lot of these patients have memory concentration problems with brain fog. They have sleep disorders where they can't fall asleep or they keep waking up in the middle of the night, right? Very, very common in this population. In my population, most do have babesia. They do have day sweats, night sweats, chills, air hunger. Many of them also will have chest pain, palpitations, and shortness of breath, right? We see this with POTS, postural orthostatic tachycardia syndrome, which you get with chronic Lyme and you also get with long COVID. So we look at all of this constellation of symptoms of depression, anxiety, sleep disorders, brain fog, memory problems, pain, fatigue. Now, the problem, of course, is those symptoms overlap chronic fatigue syndrome and fibromyalgia or myalgic encephalomyelitis. So how do you differentiate, right, those diseases from Lyme? And again, it is the migratory aspect with symptoms coming and going with good and bad days. And with women also, they'll tell you around the menstrual cycle, the symptoms get worse when the estrogen goes down, right? And the symptoms get better when they're finished with their cycle. They also will get better or worse with antibiotics, right? They herx, they get an inflammatory response when you kill off the bugs with doxycycline or amoxicillin, or they might feel better. So antibiotics make their symptoms better or worse. So for example, if your chronic fatigue or fibromyalgia was due to a virus, like herpes virus 6, or if you had long COVID, right, where you might also have loss of sense of smell or taste or pulmonary problems from the COVID, right? Those are not normally things we're seeing in chronic Lyme. They're not going to normally have those good and bad days with migratory pain. They may have pain. That's part of the complex in long COVID, but it doesn't migrate, right? And their brain fog can look like Lyme, as can their fatigue. And that's why this questionnaire is so important, because we needed to validate a questionnaire to figure out, before we do a gazillion tests on patients, what is actually the likelihood they have it. So in these 4 sections, the Lyme incidence scale, we have a CDC healthy day scale. How many days in a month did you have good and bad days with your physical, mental, emotional health? And finally, a Lyme score of like where we put 5 points, for example, if you have the constellation of fatigue, brain fog, insomnia, pain, right? We put these kind of symptoms together. And the way the questionnaire was validated is we looked at 1,600 people from 3 medical practices, and this was done at the University of New Paltz with Dr. Mariella Cetera and my good friend, Dr. Phyllis Freeman. And we validated it statistically. And what we found is that there was convergent, divergent validity, and also predictive validity, which means that from a statistical standpoint, when you're looking at a questionnaire, it had all of the aspects statistically with the p-values, meaning it's effective in finding out, at least giving you a sense of what is the probability of Lyme. So the way you score the questionnaire, and you can find the questionnaire, by the way, on my website, www.cangetbetter.com. Just go under the questionnaire, symptoms questionnaire. You'll find it. You just download the PDF. When you score it, if you have a score of 63 or higher, very high probability you have active Lyme disease. If it's between 45 and 62, it's very probable you have Lyme disease. If it's between 25 and 41, 44, it's likely, it's probable, right? But if it's below 25, it's not likely you're generally going to suffer from Lyme disease. So at least it gives the patient and it gives the physician a sense of like, okay, they scored high, I should do Lyme testing, because if someone's scoring low, it may not make any sense to do a battery of tests. But again, when I look at this questionnaire and I look at the constellation, the minute I see severe fatigue, severe brain fog in a 30-year-old person with chest pain and palpitations and sweats, right, and pain, and they tell me it's migratory, I already know what I'm dealing with. I don't need to get a Lyme test back. And what everyone out there needs to know is there's only 7 diseases in medicine that cause migratory pain. And I like making a joke for my doctor friends that unless you're at the lower end of your medical school class and graduated at the bottom, you'll generally be able to tell the difference between hepatitis, acute rheumatic fever, gonococcal arthritis, right, with a discharge, Reiter syndrome from Salmonella, Shigella Yersinia, having ulcerative colitis or Crohn's disease, or having lupus. Those are the other 6 diseases that cause migratory pain. And believe me, they look nothing like chronic Lyme disease if you've ever seen these diseases. So it's actually quite an interesting questionnaire focusing on the migratory aspect of the pain, questions 1 and 22 for Babesia. And we use the questionnaire to follow patients. So after we do, for example, the Dapsone protocol, I go back and look at the questionnaire and go, oh, look, you had severe fatigue 2 months ago. Now your fatigue is gone and your joint pain was severe. Now it's mild and you only have it a couple of days a month. So I can kind of track all the symptoms using the questionnaire. And really it tells the doctor, right, how to track the symptoms in the patients, but also what is the likelihood and should I do a battery of tests, right, looking for Lyme disease. So that's essentially some of the clinical characteristics of Lyme. Babesia, just quickly, is a malaria-like organism. So malaria, day sweats, night sweats, chills, flushing, air hunger, can't catch my breath, unexplained cough. Now, for those of you who went to medical school and you read the textbooks on babesia, you would expect me to say anemia, hemolysis, where the red blood cells are bursting apart. Don't see it in my population. Interestingly enough, when patients get Lyme and they get babesia, many of the patients never have hemolysis. They never get kidney failure. They never get the liver problems that you read about in the textbooks. And it's because of the interaction of the way these bugs are working together. And finally, for Bartonella, for the 3Bs, because these are really the three biggest bacteria as well as parasite that I see affecting my patients, Bartonella kind of looks like Lyme, but it's a way more severe version of it. So with Bartonella, severe fatigue, severe headaches, severe memory problems, severe joint pain, severe neuropathy, it really does look like Lyme. But the difference is you can get new onset seizure disorder. Oftentimes you'll get eye disorders, like optic neuritis can happen with Lyme, but it also happens in Bart. But you'll get like retinal problems with Bartonella that an ophthalmologist will be able to pick up. You will occasionally see really large lymph nodes with Bartonella. I will tell you in clinical practice, oftentimes I actually don't see it, however. What I do normally see is the classical stretch marks, the striae of Bartonella that kind of look like either white lines or sometimes they're purplish, and they can be in a Christmas tree pattern or horizontal. We'll see that with also granulomas, these bumps that'll show up on the extensor surfaces of the fingers. Those are really kind of the things we're looking for with like severe neuropathy, severe neuropsychiatric. These are the people with schizophrenia, the people with bad bipolar, the bad obsessive compulsive disorder with Lyme. Almost guaranteed these people are going to have Bartonella. And in the study we just published in Microorganisms, we showed that it was the people with multiple Bartonella species and Babesia species. The worst neuropsychiatric, the worst neuropathy with pain, with this burning, stabbing pain, sometimes it's numbness. Also the worst autonomic neuropathy with POTS, and the worst immune deficiency. The people who had no immunoglobulins or lacked subclasses, that was all from the Bartonella and the Lyme together. So when I look at, the laboratories and I look at the symptoms and the pain in the bottom of the feet for Bartonella, very, very classic symptom. Joe Borrascano described this decades ago, and he was right. Very, very classic symptom. That's kind of what you're looking for, in these patients with Bartonella. But I will tell you, the overlap is quite strong. There are some patients with Babesia, they never get sweats. About 1 out of 100, they're just horribly sick. And I'll get a Babesia FISH test. FISH stands for fluorescent in situ hybridization. It's an RNA test where the Babesia is in the blood. It fluoresces green. I will be shocked that they have Babesia, which is active, and they've got no malarial symptoms. So this is a tricky disease. You see enough patients, you'll always see kind of outliers at all end, but that's kind of the clinical presentation that you're looking for in most of these patients.
So with a clinical presentation, and it's blatantly obvious to you, right, or other medical practitioners, what is going on. You already know pretty much what the diagnosis is. Say that you need to prove it to the patient, or you need to prove it to another medical professional, or you just want the proof. What are your favorite tests and laboratories who conduct these tests when it comes to the big 3Bs?
Yeah, it's a great question. So I try and limit the tests to specialty laboratories, obviously, because I don't want patients to pay too much out of pocket. Although I will say if you're Medicare, IGeneX will cover basically all of the testing that you need for free. It's great. I usually will start off, if someone says I'm financially challenged and I cannot afford a lot of testing for Lyme, I will tell them minimally, just do an IgM, IgG Lyme immunoblot from IGeneX. And the reason being, if you do a Western blot from a standard lab from LabCorp or Quest or BioReference, it looks for one strain of Borrelia. Now, Borrelia burgdorferi sensu strictu is the original bacteria that was described 45 years ago, right, by Alan Steer. We now know that there are over 100 different Borrelia of the most common pathogenic species, including some of the IgG immunoblot, because it checks for Borrelia sensu strictu, Borrelia abzelii, Borrelia guarini, a lot of the different organisms. And I play a game called Lyme Bingo. And I suggest everybody take notes on this one if you've not played this game before, because this is how you ultimately diagnose Lyme. Someone who comes in and says, I have all of these symptoms on the 38-item questionnaire, the HMQ. I have good and bad days. The symptoms are coming and going. The joint pain, the muscle pain, and the nerve pain is migrating around my body. I've got horrible brain fog, and I do an immunoblot, and I see any one of the following 5 numbers: 23, outer surface protein C; 31, outer surface protein A; 34, outer surface protein B; 39, very specific, and the 83/93. If any one of those bands, because this is recombinant DNA, this is not a Western blot that we can get false positives. This is positive or it's negative. If any one of those bands shows up on an immunoblot, bingo, you have been exposed to a Borrelia species. It may not be the original Borrelia burgdorferi sensu strictu, but it's what we call Borrelia sensu latu. It's one of these cousins of Lyme disease that is now making people sick, like all of the different species in the US and in Europe. So I love the immunoblot. And I might do an ELISA locally through LabCorp Quest, or a C6 ELISA, which the advantage is that it checks 3 strains of Borrelia: sensu strictu, Borrelia avzeli, and Borrelia guarini. But that being said, I have many patients with the ELISA is negative and the C6 is positive, or the C6 is positive and the ELISA is negative, or both are negative and a Western blot or an immunoblot may be positive. But the point being, you don't use CDC criteria with an ELISA followed by a Western blot to make the diagnosis. Lyme is a clinical diagnosis, as we've talked about. And the way you make the clinical diagnosis is use the HMQ questionnaire, look at migratory pain, and look for those Borrelia-specific bands, having also, of course, ruled out other diseases. Because there's a lot of things, and we'll talk about this today on the MSIDS map, there's a lot of other overlapping factors, right, that keep people sick. But I'll do an ELISA. If it's negative, a C6. I'll occasionally do an immunofluorescent antibody. If I want to do direct testing, I will do PCRs. I like the FISH test, fluorescent in situ hybridization, for Babesia and Bartonella. Those are my go-to tests. Babesia FISH, Bartonella FISH from IGeneX, go-to for diagnosing Babesia Bart. But T-Labs also has some very good FISH testing. I've picked up Babesia species like Babesia oticolii through T-Labs that I was not able to pick up in other places. But all the other tick-borne testing like Ehrlichia, Anaplasma, Rocky Mountain spotted fever, typhus, Q fever, tularemia, brucella, the viruses, Epstein-Barr herpes, I do this through the local labs, right? So it's covered by everyone's insurance. And direct testing, it's useful, but I will tell you, you usually need indirect and direct testing. Direct testing is like PCR, FISH, RNA testing, or phage. Red Laboratories in Belgium will do phage testing. That's direct testing. Or you can do nanotrap, OSPE testing. And I can't do it in New York, but it picks up the OSPE in the urine. Those are direct tests that you can all use to diagnose Lyme. Usually, you're going to need a combination of many of these tests to prove it. But remember, it's a clinical diagnosis. A high score on the HMQ, any bands on an immunoblot, you pretty much got your diagnosis, but usually you have to figure out what are the other bacteria? What are the other parasites like Babesia or intestinal parasites? What are the other viruses? Do they have long COVID, right? Do they have Epstein-Barr reactivation or herpes virus 6? Do they have fungus, candida, mold? You've got to look for all of the overlapping factors because in my world, it is never just Lyme disease that's keeping these people ill.
Yeah, that's true. Okay, so Dr. Horowitz, let our listeners know how they can get a hold of you if they would like to, and let us know if you have anything new coming up.
So people can get in touch with me through my medical office at medical@hvhac.com. And for people who are interested in the Dapsone study, eventually at the end of the year, whether it's doctors or patients, research at hvhac.com. But I would ask people, please follow me regularly on Facebook, Dr. Richard Horowitz, Dr. Richard Horowitz. Anything that's new in medicine regarding the MSIDS map or Lyme or Babesia, Bartonella, I'm regularly posting for the community out there to make sure they are up to date with all of the new things that are coming out in the literature. And I will be working, by the way, on a 3rd science book. I'll be starting it sometime this year. I don't want to give away the title yet. I think I know what it is, but I don't want to give away it yet. And I will be speaking at the Southeast Regional Integrative Medical Conference in Asheville, North Carolina this summer. I was invited by Sonia Rappaport and the organizers, so that's going to be great. I'll be speaking for several days. It'll be a very intimate conference. I think docs are going to learn a lot. And I'll be at iLads in San Antonio, Texas at the end of the year for people also to follow the work.
Wonderful. So let's talk about, do you want to talk more about the questionnaire and the validity at all? Do you want to talk about
The
statistics?
main thing I would say about the questionnaire
Yeah.
is all the score, a high score on this HMQ questionnaire, greater than 63, which is 2 standard deviations. It's a really high probability. And whoever's looking at your medical charts, it tells them you've used a validated questionnaire. But regarding the testing and the questionnaire, the average ELISA followed by a Western blot, it's a coin flip. It's about a 56% chance of picking it up. The questionnaire has an 87% accuracy with validity when we looked at it from divergent, convergent, and predictive validity. So the point being, the questionnaire is actually more accurate than doing a two-tiered test with an ELISA and a Western blot. So keep in mind that I think you've got to use all of these together. And I think it shouldn't be one or the other. And again, we'll even follow the bands on the immunoblots, right? Or the Western blots to see how they change over time. Let's say somebody has done with treatment and they had a 23, 31, 34, 39, 83 band, and you check them years later, those bands may still be there, but usually they'll be gone. But let's say they didn't have a 23, 31, and 2 years later, they're complaining to you. Their symptoms are coming back. They've got fatigue, they've got joint pain, and now you see a new 23, 31 band. You know that the Lyme is reactivated because the immune system is picking up the very specific proteins on the outside of the bacteria. So I'd say use, the immunoblots and use the variety of tests we've discussed in the questionnaire together. And usually you'll be able to figure out kind of where patients are. Do they have the disease? And it's a very good way of following them over time. But it is clinical. I look at the migratory pain. I don't follow their ELISAs and Western blots to figure out if they're in remission. It's the patient who tells me they're in remission, right? Their symptoms are gone or much better. I just use the immunoblots and bands to figure out, do they still have a little bit in their body, right? I might repeat a Bartonella fish to see if they were positive. Can I still find it? Is it still active? That's where I want to use some of these tests in these chronically ill patients.
Yeah, I love that. And I love that, when you're working with a patient, it's not, there's, other than looking at, maybe some inflammatory test or immune system evaluation test, we can't, it's cost prohibitive for most people to be able to do this testing so close together, looking at antibodies with indirect tests, but also it takes so long for these antibody levels to come back down. And like you said, that could be present years later. So what I love about your questionnaire is that you can use it as a tool to see, this resolution of symptoms, right? So the decrease in overall number of symptoms and decrease in the severity of symptoms not only guides you as a practitioner that your treatment is working, but it's very reassuring. And it almost becomes like, and even though it's subjective and the patient is filling it out, over time, when you're looking at their original, compared to 2 months in, compared to 6 months in, compared to 9 months in, it's becoming objective information to the patient that they are getting better and that this is working. And because the patients are stuck in their bodies 24 hours a day, they don't realize the progress that they're making. So I think it's an invaluable tool to be able to show the medical provider as well as the patient that treatment is working and it's free. And there's
Yes,
not much else you can say that about.
it is free. Just
It is
download it off
free.
of the site. It's absolutely free. Yes, it's a great
Yes,
point.
and that's at cangetbetter.com.
Yes.
Okay. All right. So moving on to the 16-point MSIDS evaluation or map. Can you tell us a little bit more about that and how to use it?
Sure. So the example I use for patients who come to see me in my medical practice, it's like coming to a doctor with 16 nails in your foot, telling the doctor you have foot pain, and the doctor finds one of the nails, pulls it out, tells you to come back in a month, and then says, "How's your foot pain?" And it's like, obviously you're still going to have foot pain. You have 15 nails in your foot. Well, that's kind of what the MSIDS map is like. So the way I designed the MSIDS map, it's not like I came up with any of this separately. These things all existed in medicine. It's not like I made any of these points up. But what I did do, by seeing 13,000 chronically ill patients, I would keep seeing like, well, what is keeping these people ill? So the way the MSIDS map works is 6 of these factors of the 16 are inflammatory, meaning, and the way I describe it is kind of like rivers of inflammation going into an ocean of inflammation. So the reason Lyme patients, by the way, are sick and tired and foggy and have psychiatric issues is from inflammation. And there's a lot of inflammatory molecules that are produced when you have Lyme. A lot of biochemical pathways are activated. So the first part of these 6 points of this inflammatory response is what I call the 3 Bs, which we've been discussing: Borrelia, Babesia, Bartonella. Now, that's not to say there aren't other infections, because there are. Do we see viral reactivation with Epstein-Barr or herpes virus 6? Absolutely, just like you do with long COVID, right? Do we see in some of these patients candidiasis, a candida overgrowth in their gut, where they might have a fungal overlap, and they do dapsone and they're finished and they say, I still feel tired and foggy and achy, but gee, doc, I eat carbohydrates, I get gassy and bloated, I've got a coated tongue, or a woman might have some vaginitis and discharge, and I go, oh, it sounds like you're overloaded with candida. Here's a course of fluconazole. And they come back in a month and they go, I feel completely fine. That the last 10% was fungal. It was candida, right? So keeping in mind that there's 4 classes of infections: bacteria, viruses, right, fungus, and parasites. And although Babesia is the most common parasite, we do occasionally see intestinal parasites, right, that show up in these patients. And even for the bacteria, many of these patients with gut issues, which is the second and third point on the MSIDS inflammatory, is microbiome issues. You've got the wrong types of bacteria. You might have too much Prevotella species, too much Clostridium, not enough of the right type, or you've got leaky gut. You've got food sensitivities. You've got mast cell activation, a lot of inflammation from eating the wrong foods. That also causes an inflammatory response and causes the same symptoms as Lyme. So it causes fatigue and pain and brain fog. So the first 3 is the infections, the 3 Bs: microbiome, leaky gut. But then we have sleep disorders. If you're a Lyme patient and you don't fall asleep, inflammatory molecules like interleukin 6, they don't shut off. You will never have, without a good night's sleep, I sleep 6 hours one night and I'm fogged out the next day and tired, right? I need 8 hours of sleep. These are Lyme patients who sleep 4 hours a night. The inflammation never shuts off. So you've got to deal with sleep disorder. And Lyme causes delayed sleep phase syndrome. It actually causes a circadian rhythm disorder where these people don't fall asleep, right? Or keep waking up, or they sleep for 16 hours and they never feel refreshed. The last 2 of the inflammation is that there are toxins, many toxins, getting into people. We'll talk mainly about heavy metals and mold, but truthfully, there's hundreds to thousands of chemicals getting into people. And then there are nutritional deficiencies, whether it's vitamins and minerals, where people can't detox these chemicals properly. So if you don't have enough magnesium, the 300 enzymes in your body don't work. You don't have enough copper. There's an enzyme called superoxide dismutase. You get a lot of inflammation. You don't have enough zinc. Also, you can get aldehydes being produced, which cause brain fog. So all of these 6 factors out of the 16, they're like rivers of inflammation, and they have downstream effects on the body. And what are the downstream effects? Autoimmunity, just like long COVID, right? You'll get ANAs that are positive, anti-nuclear antibodies, rheumatoid factors, Hashimoto's antibodies with anti-thyroid antibodies, anti-ganglioside antibodies, anti-myelin antibodies. It's a big autoimmune factor, but that doesn't mean you have rheumatoid arthritis or lupus or an autoimmune disorder. It means that the inflammatory response from the bacteria and everything else going on is causing autoimmune reactions. But usually once you treat the underlying factors, the autoimmune reactions actually will get much better. But you'll get this inflammation affecting the vagus nerve, the part of your body that controls your heart rate, your bowels, your blood pressure, your bladder, and that causes POTS, postural orthostatic tachycardia syndrome. You stand up, you feel like you're going to pass out, or you do pass out. You're tired, you're foggy, you're anxious, you have palpitations. Well, those are symptoms of POTS. Now, you could have gotten rid of all of the bacteria with Lyme and Barrett and treated the Babesia. But if you don't treat the POTS or know you have it, you may keep giving people antibiotics or herbs ad infinitum, thinking it's still an active infection, but it was the vagal dysfunction, right, that caused the problems. Or the inflammation affected their pituitary gland and their hormones. They get low adrenal function. Men get low testosterone. The mitochondria, the parts of the body that make energy, there's nothing to protect them from all this inflammation. So you get mitochondrial dysfunction, you get nerve pain and pain disorders and liver dysfunction, and a lot of neuropsychiatric dysfunction from all of the inflammation. So what's important here to realize is when someone comes in and we call it chronic Lyme disease, right? It is not chronic Lyme disease. It is really, for me, Lyme MSIDS, meaning every person is going to be completely different. Some people will have 4 nails in their foot. Some people will have 12 nails in the foot. And your job as the medical detective is to figure out what are the nails and to treat it. But that's kind of an overview and why the MSIDS model is so important and why when we do this randomized trial, I'm going to probably screen for at least 3 months before dapsone, because these are factors that interfere with the success of the antibiotic protocols. So we need to show to the community that it's not just Lyme. And unfortunately in medicine, I don't know if you were taught the same thing, Mariah, but we were taught one cause for one disease, right? It's like Pasteur's postulate or Koch's postulate from the 1800s. Well, in the 21st century, folks, it's not. It's multifactorial. It's no longer one cause for one disease, right? It's usually, in my patients, Lyme, Babesia, Bartonella, POTS with vagal dysfunction. Most have mold. Many have heavy metals. Most have nutritional deficiencies. Many have mitochondrial. They have pretty much all of this. And in the articles we published, about 70% of the time, most of the patients have most of these MSIDS factors. So it's a really important, and I discussed these in my first book, Why Can't I Get Better? Solving the Mystery of Lyme and Chronic Disease, which was a New York Times bestseller, and in How Can I Get Better? Right? An action plan for treating resistant Lyme and chronic disease, both from St. Martin's Press. So this 16-point MSIDS model and treatments, it's all in these books. And the last book, How Can I Get Better, has some of the dapsone, although I will tell you, when I published the last book in 2017, I was just discussing dapsone at that point. I started it in 2016. Boy, have we come a long way. If I was to write the third book, which I'm going to write, it will be beyond Lyme. It will be about how this MSIDS model affects a lot of these different chronic diseases, because Lyme is showing up under Alzheimer's biofilms. We're seeing Lyme in some cases in autism spectrum disorders, in people with ADHD. I mean, all of these chronic diseases that we're having, 87% of the healthcare costs and 70% of the deaths in this country are chronic illness, and we don't have a model. I'm proposing that this 16-point MSIDS model is a good starting point, because it doesn't matter what you're labeling, your chronic fatiguing, musculoskeletal, neuropsychiatric illness, usually the MSIDS model is going to kind of put you on track to figure out what's going on.
Yeah, I agree. I think that model is fantastic. And, you know, from someone who was trained pretty much in the functional medicine arena, like straight through and out of medical school, yeah, this is more how my mind works. So I often, you know, will tell my patients, Lyme, you know, if it's an infection, whether it's Lyme or some other tick-borne disease or any other infection that comes in, causes massive inflammation, kind of breaks the immune system, and then all hell breaks loose, right? And it's your genetic weaknesses and your SNPs, but it's also previous injuries. It's what makes you you, and what those weaknesses are. That's where these infections are going to go to, right? And so if you have gut issues, right, or your microbiome is not balanced, and you have you know, issues in the gut, and that's your weakness, that's going to be one of the places where Lyme is going to wreak the most havoc. And then if you have Bartonella, forget it, you know. But it's like, it's different in every person because we all have different weaknesses. And I always say, like, the infection goes there like a magnet. And so you can focus on killing the infection until the cows come home. But like, if you're not restoring the terrain and restoring proper function to the body and helping to, you know, inhibit the inflammatory cytokine cascade, balance the immune system, heal the patient, they're never going to end up better.
No, and that's the point. You know, you learned that in your med school. I had to figure this out, by the way, myself, because even though my 7-year medical program in Belgium was great, I wouldn't say terrain, the notion of terrain, even though the European system is generally much more open and broad, that notion of terrain, I don't think was stressed in exactly the same way. And you brought up an important point about like the immune system and inflammation. Just for example, one of these points on the MSIDS model, immune dysfunction. We talked earlier that Lyme and Bartonella can affect the immune system, right? In the studies I've published, and Nicole Baumgar showed this in the mice model, when Lyme goes into the lymph nodes, it gets rid of the B cells, the cells in your body that make antibodies. So it gets rid of the IgG antibodies, the ones that are the most effective in clearing the infection, and it leaves IgM. So when you're a Lyme patient and you go for a Lyme test and you bring to your doctor your CDC positive IgM, not IgG, IgM immunoblot or Western blot, and your doctor says to you, oh, that's a false positive, right? That's only an early Lyme. It's not true. That actually is the most common manifestation in late Lyme is a CDC positive IgM blot because Lyme knocked out the IgG antibodies. And if you go check people's immunoglobulins and subclasses, you'll see with bad active Lyme and Bartonella, it's been knocked out. They're immune deficient. So how can you throw herbs or antibiotics at people and you've never checked their immunity to see how they fight? It's like with COVID. If you don't check natural killer cells, the type of cells in the body with the CD8 that go after the viruses, and you don't know how they're functioning, how do you know how someone's going to get over COVID, right? Or if you don't know their antioxidant pathways and their glutathione. And long COVID is really becoming a problem because it does look like chronic Lyme, right? Brain fog, fatigue, pain, POTS dysautonomia, sleep disorders, neuropsychiatric. It's pretty much got the same symptoms, but with Lyme, it's good and bad days. Symptoms come and go. Antibiotics make it better or worse. Women have the hormonal flares, right? You've got the bans, of course, on the immunoblot, but let's face it, there's a lot of people out there. It's not going to be just long COVID. It will be long COVID and chronic Lyme and BART, or it might be Bartonella without Lyme with long COVID. We're dealing with an infectious soup these days, and doctors really need to know how to make the diagnosis and differentiate this because we're seeing this in our practice. Fortunately for me, by the way, we published the first article in April 2020 after the COVID pandemic just started on glutathione deficiency in COVID. We actually published the first article. It's been cited over 250 times. And what we discovered is that, and I knew this from Babesia, the patients they came in with Babesia who were short of breath, and I gave them a 2-gram shot of glutathione, and they said, oh my God, my shortness of breath is gone. When patients were coming in with COVID and describing the shortness of breath, I said, gee, I wonder if that's going to work like it does for Babesia and Lyme patients. And sure enough, it did. So we published 2 case studies. Now it turns out all the people in the ICUs, they've now shown that these are the people with the lowest glutathione levels because there's 140 times more glutathione in your lung tissue than any place else in the body. So if you've used up glutathione, which is your primary antioxidant to detoxify the body from chemicals, right? If you don't have enough and you get COVID, that's where you're going to end up with problems with lungs and, of course, inflammation in multiple body tissues. So, knowing the biochemical pathways and having done this for Lyme, it turned out I was able to provide at least a protocol. We've not had one COVID patient die in the last 4 years, and I've only had 2 hospitalizations. One was on a ventilator. She was in her 70s, and both were boosted and immunized, right? It just was, one was immune deficient and the other also had problems. But other than that, no hospitalizations, no deaths, and no long COVID, just by using the protocol for COVID that, again, is on our website. Go to cangetbetter.com under the COVID tab and look at treatments. And by the way, those treatments are the treatments for Herxheimer reactions. Mm-hmm. It's the same treatments we used for Lyme. We block a pathway called NF-kappa B with N-acetylcysteine, alpha-lipoic glutathione. We stimulate an anti-inflammatory pathway called NRF2 with turmeric, curcumin, broccoli seed extract, sulforaphane glucosinolate, resveratrol, and green tea extract. We block an inflammatory pathway called NLRP3 inflammasomes with low-dose melatonin. We block microglial activation in the brain with low-dose naltrexone. All of the tricks we've learned for Lyme, I know you've done this too, they ended up working for COVID. And just yesterday, they published that earlier studies showed Paxlovid was helping stop long COVID. Now they're not so sure that we don't actually have an answer for it. So, I'm thinking maybe blocking these inflammatory pathways early on has helped my Lyme patients because I'm not really seeing a lot of long COVID in the chronic Lyme population.
I was just going to say the exact same thing. Most of my patients, so same, I don't think in my practice we even had, well, we did have one person who was severely immunodeficient and on immunosuppressant drugs who ended up in the ICU with COVID. But other than that, I mean, we have not had really any severe cases of COVID. And, my sort of theory behind that is that most of our patients who are being treated for chronic tick-borne disease are on a myriad of herbal medicines that shut down interleukin 6, interleukin 8, interleukin 1 beta, tumor necrosis factor alpha, NF kappa beta, all of these, that the MAPKs, like all of these cytokines, inflammatory cytokines that are causing a lot of the issues. And a lot of these herbs actually protect like the ACE2 receptor and linkages and actually stop that whole the whole ignition like right from the beginning with the cytokines. So on top of that, with people eating the best that they can eat and trying to live a healthier lifestyle and all of the things that we do to really address like all of the things that you're talking about. And I just think that the healthier you are when you're exposed to something like this, and if you have all of those little blockages in place, you're going to do so much better. Um, but what do you think the relationship is? Do you think it's the inflammatory cytokine cascades and like the alteration of the immune system and that immune imbalance that the spike protein, whether it's from a vaccine or whether it's from having wild COVID, do you think that that is what can cause a reemergence of a dormant tick-borne infection? Or do you have a different theory?
I mean, these, of course, are really great questions. They're unanswered questions for the most part. When I look at the literature on long COVID and I look at the MSIDS map and Lyme, what's interesting is 7 to 8 of the factors of the MSIDS map we've been discussing today have all been discovered for long COVID. Why? Infections and inflammation causes immune dysfunction. So whether the inflammation is Borrelia burgdorferi Lyme causing inflammation and immune dysfunction, or it's a virus, COVID-19, causing inflammation, immune dysfunction, they've now shown in long COVID the same autoimmune reactions, the same changes in the microbiome of the gut. They've shown mast cell activation in a lot of these patients. They've shown active virus in the colon of some of these patients, lowering down serotonin. They found Pott's dysautonomia because the vagus nerve was affected by this, right? They've seen viral reactivation with Epstein-Barr. We also see it with herpes virus 6 and other viruses. So when we're looking at like the overlaps of the MSIDS model of chronic Lyme and long COVID, infections, inflammation, and immune dysfunction applies in both models. So I think the reason we're not seeing these complications is glutathione. What they've shown with the COVID virus is it needs to lower glutathione levels to replicate. So this, and I didn't know that, of course, when I published the articles. We published 2 articles in April and in May of 2020 on this, one on the need for a randomized trial on this protocol. But ultimately, now that we know that the MSIDS factors are showing up, I think it would be fascinating, and we designed the trial, it's just the FDA wanted me to use a placebo, it was too difficult, to actually look at glutathione early on, the same way we're doing it for our Lyme patients who get COVID. And by the way, the other interesting fact, apart from glutathione stopping viral replication, is that dapsone, which a lot of these patients have been on, it's shown that in some of the studies where they use dapsone, like the earlier virus, like the alpha, when it first came out, there was all of this ARDS with whiteout of the lung where people are dying of lung disease. Dapsone stopped ARDS in a study that they published in around 40 patients where they did give them dapsone, they didn't give them dapsone. Dapsone completely shut down the inflammatory cascade. And the reason, by the way, I love dapsone, and we've talked about in earlier talks, but the quality of the drug, of why, like initially I said, can I use this with COVID? The reason you can, it's anti-inflammatory. It hits an enzyme called myeloperoxidase. So it lowers down these inflammatory cascades that people also get with COVID. It has great penetration into the brain. I don't have to use IV anymore. It's anti-malarial. Babesia shows up in a lot of these patients. It's used for autoimmune diseases. We know that Lyme patients get these autoimmune reactions. And it's a persister drug, meaning it hits these persister bacteria. It checked off all the boxes that you needed for a drug. So early on, I would think, gee, I can't leave them on it. But now actually, when patients get COVID, I'm leaving them on the dapsone protocol. I'm actually not changing it. I'm just using like 2,000 milligrams of glutathione a couple of times a day with higher dose NAC. I'm just blocking all the inflammatory pathways. And again, for those of you listening, If you just go under cangetbetter.com under the COVID tab, the entire protocol is there, including, by the way, all the biochemical pathways and studies that I wanted to do.
So do you think that your patients had a less severe outcome with COVID because the majority of your patients are on dapsone?
I'm not sure if it was just from the dapsone. I'm fairly sure the NAC glutathione played a role. And the reason I think it was also important with the NAC, which is the precursor of glutathione, is that these people that got microclots, right? We were seeing all these pulmonary emboli and microclots in the people with COVID. I haven't seen one of them. And when you look at the properties of N-acetylcysteine, which we use regularly in the Lyme population for herxes with glutathione, it blocks von Willebrand factor. So I take NAC on a regular basis. I've had COVID twice. I mean, I've been vaccinated and I've had COVID twice and I've used Paxlovid. I'm fine, as is my wife at this point. But the point being, I think the NAC and glutathione, on top of blocking these other inflammatory pathways, NLRP3 with melatonin, and they're on vitamin D, and they're on zinc, and they're taking 3,6-beta-glucan immunotics to raise up their natural killer cells to fight. I mean, I designed the protocol, in fact, before I really knew all the biochemical pathways of COVID, just to block inflammation and kind of support immunity and support a healthy inflammatory response, kind of what we do for Lyme. It's worked. So I think the dapsone may be part of it, but I actually think it actually is the NAC glutathione component helping to stop the viral replication and stopping the microclots. And that, of course, would have to be proven on a randomized trial.
So most of your patients are on NAC and glutathione as
Oh,
part
yes.
of their, okay.
Oh, absolutely. They're, in fact, the core protocol, they're all on NAC, alpha lipoic acid glutathione to block NF-kappa B, minimally on a turmeric compound like Curcuplex, Oncoplex, which is sulforaphane glucosinolate, broccoli seed for NRF2 activation. If they have a sleep problem, they're on a touch of melatonin. Most are on low-dose naltrexone. So they're on all of these supplements because they help with herxes. They help to lower the inflammation, right? Because the Lyme patients get tremendous inflammatory responses. And interestingly enough, in long COVID, the H1H2 blockers, right, are helping some of these patients, like when they get mast cell activation. So a lot of what we've learned about Lyme actually is overlapping and helping a lot of these patients with COVID.
Yeah, it's amazing. I don't know if I would have known how to help anyone with COVID had I not specialized in treating tick-borne disease. So before we wrap up, could you just elaborate a little bit more about mycotoxins, heavy metals, other toxins, when it comes to treating tick-borne disease and
Sure.
using the MSIDS map?
Yeah, it's very important to look for these toxins that get in the body. And again, as we talked about earlier, there's hundreds to thousands of chemicals getting to everyone. And these are hormone disruptors. They cause insulin resistance. They cause cancer. I mean, they're horrible, which is part of the reason I take NAC and glut all day long, actually. I take it at least twice a day. But mold and heavy metals, the reason you've got to look for them is when we did the studies early on, and I presented this at Lyme conferences literally 20 years ago. When we started looking for heavy metals like mercury, lead, arsenic, cadmium, aluminum, what we discovered is not only that patients had these, not just in their blood, but they had them in their tissues on a 6-hour urine DMSA challenge. But in certain of these patients, after we treated them with antibiotics and they said, gee, I still have fatigue and brain fog and pain, and then we pulled out the heavy metals, they went, doc, I feel completely well. It was like, what? It's like, oh, the heavy metals were responsible. And interesting, there are studies published on bugs like chlamydia pneumoniae that when you add heavy metals like mercury and put it in a joint tissue, the inflammation goes wild. And if you don't put heavy metals in there, you don't get the same inflammatory response. So I think the metals are increasing the inflammation we're seeing from these biofilm persistiforms. So you've got to look for the metals and especially the mold, because now that I'm doing dapsone in pretty much everyone coming into the office, we are finding mold. In the last study we published, it was 84% of our patients. And earlier on, I used to joke with Neil Nathan, who's a good friend of mine and mold expert. And I'd say, Neil, I'm finding the mold in a lot of these patients, but it just doesn't seem to be playing as large a role as the Lyme, Babesia, BART, and the MSIDS factors. And of course, in the past year, now I've had a couple of cases, the last few months exactly, one is in Europe and one is in Florida. Lyme, Babesia, BART, did the dapsone, did the 9-week, did dapsone pulses, would get better, but kept relapsing. And more than I would have expected. And neither of them admitted to having mold exposure. And I said to them, listen, you're in Florida, which of course there's a risk of it. And this other patient was in a part of Europe where there's a lot of water. And I said, just do me a favor and send off the real-time labs mycotoxin test. Let's see what you got. They were positive on all 5 mold toxins. And what was really fascinating to me is I'm no longer doing any Lyme, Babesia, Bartonella treatment, but by simply opening up the detox pathways and giving them NAC, alpha-lipoic acid, glutathione, phosphatidylcholine, 3 grams of phosphatidylcholine twice a day, with binders. If they have trichothecenes, which is one of the mold toxins, we're using something like optifibrilline glucomannan an hour away from food to pull the trichothecenes. But otherwise, we're using GI detox. It's a product from Biobotanicals with charcoal clay, bentonite clay. We'll sometimes use chlorella. We'll use that 2 hours away. But by using GI detox, using optifibrilline, phosphatidylcholine, glutathione, little bit of N-butyrate, 500 milligrams twice a day, these patients that said to me, gee, I was getting better with the tick-borne and I'm now really ill, all of a sudden are miraculously well. And I mean, I've been doing this for a long time. This shocked me. The one in Europe, he had done 7, he had 6 with 6 pulses for the BART. He was active and was better, but something was wrong. And after he started detoxing the mold, he got back to me and said, I am 99%, 100% better. I cannot believe the only thing that was not getting better was libido. We didn't really talk about this much, but Lyme kind of knocks the libido out, right, in most people who have this. And the one in Florida, I started detoxing her and she couldn't even tolerate 1 capsule. She got sick as a dog. We gave her the Byron White Detox 2. It's another form of charcoal clay in a very small amount. And once we figured out the amount to pull the toxins through the detox pathways, when we found the right amount, she emailed me and went, Doc, that is it. I feel the best I have felt in years. So even though I used to joke with Neil about, oh, come on, mold, we're all being exposed. What's the big deal? I have to tell you, the more I do this, yeah, it's a big deal. And especially because the gliotoxins that are showing up as one of the mold toxins are immunosuppressive. So if Lyme and Bartonella are suppressing your immune system, and anaplasma can suppress your immune system, and gliotoxins, because you don't want to have a lot of immunosuppressive factors in your body when you're trying to get over these tick-borne infections. So we need to remove the mold toxins, both from the point of view of your immune system's response, but also because some of these patients, the fatigue, the brain fog, the pain, the neuropathy, it is related to mold and it's related to heavy metals. So really important points. And it's personalized, as we talked about earlier. You don't actually know who is going to get better from this, right? People can test, by the way, and test positive, and it doesn't mean it's a major nail. I've had patients where they have 16 MSIDS factors all show up, and it was the adrenal. It was the phase 3 adrenal dysfunction. You put them on a little bit of adrenal support, hydrocortisone, whatever, and they'll go, I feel great. And they have all of the other 15 factors that have not even been addressed. So this personalized, precision medicine model, even when you test positive for all these things, it doesn't even tell you the role of each of these. You've got to kind of go in there for the patients and find out for yourself.
Yeah. Like I say, it's one big giant ball of wax. And a lot of times you have to deal with the whole thing at once. So any piece of advice, if you just had one thing that you could put out there to our listeners, what would it be before we wrap up?
So for those of you who are listening who have chronic Lyme disease and associated co-infections, the Dapsone protocol that I have been developing during the last 8 years, it takes a lot for me to be speaking to you directly and telling you with confidence that if I had chronic Lyme, this is what I would be doing with my doctor. We do doctor trainings every year to train the doctors in this. I would just tell you, it is published in the medical literature, the entire protocol. And if your doctor needs help, your doctor can contact me. I do this all the time, but please do not lose hope. There is hope. And the Dapsone protocol and other persister drug regimens, occasionally even disulfiram, which we haven't talked about today, but we'll talk about in future episodes from Ken Liegner's work. These persister drug regimens are working. And the MSIDS model, once you figure out What are the inflammatory factors, the rivers of inflammation going into the ocean? Do you have POTS? Do you have mitochondrial? Once you figure out all of these 16 factors, you will get your health back. I mean, I would not be here doing this. Mariah and I will tell you this, that these talks are a lot of work. The only reason we're doing them is for you. It's because we care about you. We care about your health. We want you to be better. This is an epidemic worldwide at this point, and we have solutions for you that are being discussed during these doctor talks. So I hope you will stay tuned and listen to the episodes. We do have solutions for you, but please don't lose hope. There's a lot of discoveries that have happened in these past couple of years, and I'm really excited to share them with the Lyme community.
Thank you so much. Thank you for all of that information. And thank you to all of you at home for listening. We will see you at the next episode. Take care.